topic today is being presented by Dr. Magwali, Trends 2006 to 2014 in reported vulval cancer in Zimbabwe. Very interesting talk. A few ground rules. Please join the meeting with your real names. Don't use pseudonyms or names of your phones. It's important for collection of CPT points. Let's allow the presenter and occasionally the host to share their video so that we avoid a lot of background distractions. Let's get everyone muted. And if you want to raise a question, I think the best platform would be to add them on the chat box so that we can then attend to them at the end of the presentation. And for those who want to raise hands or ask questions at the end of the presentation, you can show by raising your hands, and you can physically proceed to ask your questions. But I think as we go, because we don't allow interruptions to the presenter, as we go, you can send your questions on the chat box. Over to you, Dr. Magwali.
Thank you very much. There is an echo. Maybe someone hasn't muted their mic. Yeah, it's gone now. Okay. No, that's fine. So our presentation this afternoon is going to be, like Dr. Mateveke said, Trends 2006 to 2014 in reported vulval cancer in Zimbabwe. It's a sub-analysis of the reports of the Zimbabwe National Cancer Registry that we did for that period 2006 to 2014 in an effort to see what the trends in the number of reported cases was over this time period. The authors of this work are those that are listed there above the title. So to set the ball rolling, just a few words on the Zimbabwe National Cancer Registry. The Zimbabwe National Cancer Registry is a population-based cancer registry. It was established in 1985. It is a member of the International Association of Cancer Registries, and it is a founder member of the African Cancer Registry Network. So the Zimbabwe National Cancer Registry adheres to international standards of cancer reporting and cancer surveillance. As we all know, vulval cancer is a relatively rare gynecological malignancy, and incidence rates in the developing world they range from 0.96 to 1.27% of all gynecological malignancies. The 0.96 there is from India, and the 1.27% is from a place called Azikiwe in Nigeria. In the United States, they reported it as 4% of all gynecological malignancies. And then in Germany, they reported an incidence rate of 3.6 per 100,000 women in the year 2011, whilst in the UK, it was reported as 2.51 per 100,000 women for the period 1990 to 2009. The incidence of vulval cancer has, however, been noted to be on the rise. For example, in Austria, they recorded a rise of 157% in the decade preceding the year 2000. While in the UK, they recorded 18% for the time period 1990 to 2009. And then in Germany, they recorded a 6.7% annual increase between the years 1990 to 2011. And then in the United States, it was a 1% annual increase between the years 1973 to 2004. In our local setting, we've also unpublished hospital data, which suggests that there is a rise in incidence of the malignancy, and also that it is commoner in HIV-infected women. So for the increase that was noted in Austria, they postulated that this was due to possibly an increase in human papillomavirus infection in their population, an improvement in the surveillance methods, and also increased diagnostic ability among practitioners. And then in Germany, they also thought the same thing, that the increase in incidence was due to a rise in HPV infection and also increased tobacco smoking among women, since tobacco smoking is one of the recognized risk factors for vulval cancer. In the United States, they also thought the same, that it was due to an increase in HPV infection. Although in their case, they acknowledged that the trends in HPV infection in their population were actually unknown at that particular point in time. Our last review of vulval cancer was done 31 years ago at Harare Hospital. And it was a combined incidence of vaginal cancer and vulval cancer, which covered a time period of 3 years. It was done by Professor Kasule and was published in 1989 and showed that vaginal cancer and vulval cancer made up 3% of all gynecological malignancies. So, like we said, we did a sub-analysis of data from the Zimbabwe National Cancer Registry between the time period 2006 and 2014. Our objectives were to determine the trends in the number of reported cases between that time period, and also to determine the trends in the proportion of gynecological cancer, that was vulval cancer, for that time period, and also to determine the most affected age groups. So the study was approved by the Zimbabwe National Cancer Registry and the Harare Hospital Ethics Committee and the JREC. JREC is the Joint Parrenyatwa College of Health Sciences Research Ethics Committee, and also by the Medical Research Council of Zimbabwe. So during that time period, 2006 to 2014, there was a total of 9,942 gynecological cancers reported. 81.7% were carcinoma of the cervix, 6.4% was ovary, 4.5% was cancer of the uterine body, and 1.7% was gestational trophoblastic disease. So the total number of vulval cancers that were reported was 279, meaning that vulval cancer constituted 2.8% of all gynecological malignancies overall. So that is just a tabulation of the number of reported cases there, showing that in 2006, there were 16 reported cases, going up to 17 in 2007. And the peak was in 2013, where there were 54 reported cases. And also the trends as of vulval cancer as a proportion of all gynecological cancers. In 2006, vulval cancer made up 1.8% of all reported gynecological malignancies, rising to 2.3 in 2007. And the peak was in 2013, where it constituted 3.9% of all gynecological malignancies. And that's just a graphical presentation of the trends in the proportion of gynecological cancer that was vulval cancer, showing again that peak in 2013, where it was 3.9%. And then as far as age groups were concerned, in 2006, the majority, that is 43.8%, were in the 55 to 69 years age group. But after that, it changed. And for the rest of the years, the majority were either in the 25 to 39 years age group or in the 40 to 54 years age group for each year. But for all the years combined, the majority were actually in the 25 to 39 years age group, constituting 41.9%. And then the second group was the 40 to 54 years age group, constituting 30.8%. So of note was that the number of reported cases increased between 2006 and 2014, and so did the proportion of gynecological cancers that was vulval cancer also increased during this same time period. And this is in keeping with the findings that were found in Germany, UK, and the USA that we alluded to earlier. And also, just like what the German study showed, there were more cases reported in younger women in our particular series. And like the other researchers, we postulated that this increase in the number of reported cases could be due to improved surveillance by practitioners, improved reporting, and also maybe an increase in HPV infection. And also maybe an improved survival in patients who are HIV infected and are on ART, because vulval cancer is known to be HPV related, and longevity in an individual with persistent HPV infection gives time for the oncogenic changes to take place in the vulval epithelium. So this work is not yet finished. We plan to update it. Of most importance is that we would like to calculate the incidence per 100,000 women. This would be crude incidence rates, and then we'll calculate them for each year, and then also overall. And also would like to calculate the age standardized incidence rates. This is more important because age standardized incidence rates are more accurate at showing how the trends really are, in what direction they are going, because they control changes in population structures over time. Our challenge at that time, but hopefully not at this time, was getting population figures for each of these age categories from ZimStats, because we need that. We need for the age categories that we were using, we need to know the number of women who were in each of those age categories in Zimbabwe for each of these years. So we can use one of the years as the standard year and then calculate the age standardized incidence rates based on that. That will give us a better picture of what's happening to the trends. So first of all, we'll update the reports to the year 2020, because in the initial work, we had finished at the year 2014. So, and then after that, we'll do the incidence rates and also the age standardized incidence rates. And also, we would like, where possible, to correlate vulval cancer with HIV infection, which was not quite possible with the way the records were being kept prior to now, and also, if possible, to correlate with human papillomavirus infection. A prospective model, we tried to follow up patients with vulval cancer prospectively, in order to build a database, but it proved to be a bit difficult because of the lower incidence of the malignancy compared to other gynecological malignancies. But we hope that with computerization and centralization of the records, we'll be able to do this, such that if a patient is seen on the ward during their review, or in the outpatients department, or in the radiotherapy unit, we can be able to access their updated information without actually having to physically see the patients, because some of the patients pass through the net, because when they come for review, they actually go to the radiotherapy center, and we don't get to update our records. This is the publication that emanated from that initial work. During the same time period, we followed up 14 patients prospectively, and this was from the 1st of March 2016 to the 21st of October 2016. And we managed to have the records for those 14 patients. But somehow, after we had recruited those 14, the number of new patients coming in dropped drastically. It was only the same patients coming for review, and sometimes would miss them because they would fail to come for review. Our intention was for long-term follow-up, but we had challenges with this follow-up because of problems with communication, and then sometimes patients failing to travel for their scheduled reviews. But just a snippet on those 14, we know the number is too low to do any statistical analysis. We hope to build it up. As soon as the situation goes back to normal, we'll try to start again, follow up the patients, the old ones and the new ones as they come in, and build up our database further. But the average age of these 14 was 40.9 years, and the range was from 19 to 70 years. The oldest was 70 years. And then those who were 19 years to 30 years were 4. Those who were 31 years to 40 years were 2. And then those who were 41 years to 50 years were 4. And then those who were 51 years to 60 years were 3. And above 61 years, we had 1, the one who was 70 years old. And their parity ranged from 0 to 7. None of the patients were cigarette smokers, I suppose, in keeping with the trends in the general society in our part of the world. And only 1 said she drank alcohol. 9 gave a history of vulval warts in the past, and 9 said that they actually had pruritus vulva, which is one of the most common symptoms, together with a vulval growth in patients who are presenting with the CA vulva. And all 14 of them said that they had either a vulval growth or an ulcer, and 4 said they had a vulvovaginal discharge. 8 had vaginal pain, and 2 came in with the vulval bleeding. We allowed multiple responses as far as the symptoms that were present was concerned. And then the average duration of symptoms was 25.5 months, with a range of 2 months to 60 months. One of the issues with vulval cancer has always been that patients present late, and even when they've been seen by practitioners at the primary care level, it takes an average of 12 months for them to be referred for assessment by a gynecologist and for biopsy. But we hope that with sensitization, this is changing gradually. On staging, 4 of the patients were staged as stage 1B, and then stage 2, there were 4, stage 3, there were 5, and then stage 4, there was 1. And then, like in most series, because in most series, squamous cell carcinoma constitutes up to 95% of cases of vulval cancer. So far, 7 have been found to have squamous cell carcinoma of those patients whose records we have so far. And then 1 had an adenocarcinoma. Unfortunately, this turned out to be an adenocarcinoma that was arising from the large bowel. And then I think she went on to have bowel resection. And I think some colleagues actually wrote it up as a case report, which got published. 1 had fibrosarcoma, which kept on recurring. And then 1 had a choriocarcinoma, where the choriocarcinoma when was then sent for serum beta ECG test, and then she went for chemotherapy for gestational trophoblastic disease. 4 of the patients said at the time they were recruited did not have a histology report yet. And then all of the 14 patients had a recorded HIV status, and 10 were HIV positive, and then 4 were negative. We hope that as the database builds up, as we get more patients onto the database, we'll be able to do an analysis to show unequivocally that being HIV positive is a risk factor for vulval cancer. And then all who were HIV positive were on antiretroviral therapy. At the time of recruitment, 7 of the patients had already had surgical treatment. And the type of surgery that they had, 5 had wide local excision. 1 had wide local excision plus ipsilateral lymphadenectomy. And then 1 had wide local excision plus bilateral lymphadenectomy. 2 of the patients had wound breakdown, which is one of the common complications after surgery for vulval cancer, and 2 developed wound infection. 1 had started chemotherapy at that time, and 2 were undergoing radiotherapy. So yes, like I was saying, we are going to, as soon as these things get back to normal, we're going to try to restart the longitudinal study with follow-up of the patients, the treatment that they have, the outcome of that treatment, and also hopefully with time we come up with the 5-year survival rates, which we hope to relate to the stage of the disease at the patient at the time the patient presented to us. And then also, we hope that in future sessions, CME sessions of the Histology will be able to discuss vulval intraepithelial neoplasia and also the management of vulval CA for the surgical, the chemotherapy, and the radiotherapy, because a lot has changed in that field as well. Okay, thank you very much. Dr. Mateweke, over to you.
Thank you very much, Dr. Magwali, for an insightful talk. I like the fact that it really rallies well with what's happening within our situation, and these are our own local data and local statistics. So quite very commendable, and we are very happy that you are partaking on this study. I do not see anything or any questions being raised on the chat platform. I would at this point ask any participants that have got key questions for the study team and Dr. Magwali to show by raising your hands.
Dr. Mhlanga has raised his hand.
Okay, so maybe you can go ahead, Dr. Mhlanga.
Well, thank you, Mateweke, and thank you, Dr. Magwali, for leading this discussion. I have like a point, when you were presenting, I was just thinking aloud here and say, if you look at the oncogenesis and you take risk for risk, like amongst the HIV positives, I've just been thinking aloud and say, if the method and the mechanism of oncogenesis is the same, why is it that some people get cervical cancer, some people get vulval cancer from the same HPV infection and at different times? It's just something that intrigues me, and I was asking as someone who's reading deeply around these subjects, what your thoughts are.
Yeah, it's something that I've thought about as well, but in the literature so far, no one has addressed that. It's a very interesting question, actually, yes, that among HIV positive patients even, and then those with persistent HPV infection, especially 16 and 18, some go on to develop cervical intraepithelial neoplasia, some develop vulval intraepithelial neoplasia. Also, the question is what predisposes some to cervical intraepithelial neoplasia and some to vulval intraepithelial neoplasia. Yeah, it's something we could, I'll look again, but I haven't found anyone who has particularly addressed that. It's an interesting question, yes.
We could even extend it to say, what is the differential in the rate of progression amongst the different people who get this affliction, because I just don't understand how many factors feed into this equation, because some people, it takes a long while to get vulvar cancer. Similarly, it takes a long while to get cervical cancer. Some get cervical cancer, some get throat cancer, but you hardly find people get all of the three at the same time. So I just don't understand how. It's just something that I was thinking about and saying, what is the mechanism for this?
Yeah, very interesting. Yes, it's something that I'll try to do a literature search on that to find out why it is that some people are more predisposed to cervical intraepithelial neoplasia and some to VIN. Yeah, it's something that we could actually look at in a literature search.
If I may also ask Dr. Magwali, in your prospective collection of this data, what are your sources? Because I strongly believe that probably the numbers might be much more than the ones you actually got from the cancer registry. I don't know. What are your sources? I know of clinics like Newlands Clinic that have special clinics for people with warts and things like that. Are you also getting your data from there?
For the National Cancer Registry data, if someone is diagnosed with CA cervix or maybe CA vulva, from there, they actually get reported to the Zimbabwe National Cancer Registry will capture them. So there is a risk of double counting if one tries to get from both places.
Okay, that's fine.
But a more pertinent question is, but our Zimbabwe National Cancer Registry is I'm sure it's doing quite well as far as capturing the information is concerned. But one would maybe naturally ask that, are there no other cases that might be missed every now and again? But for institutions here in Harare, I really believe that the data collection is thorough.
Okay, thank you so much. I saw Prof. Chirenje did raise his hand. You can go ahead, Prof.
Well, thanks, Bismarck, and thanks to Lani for that talk. I just wanted to go back to Felix's discussion about why some women are spared invasive cervical cancer and they end up with vulva. Why is the selection pressure, as we may call it, particularly among HIV-infected women? And I think you have to also just go to the basics of HPV transmission itself. And there are definitely, I mean, the weakness you have in sites like ours is that there's very unreliable screening. So you will not have an index. And none of these women, I believe, would have had HPV testing in terms of sampling from the cervix. So, but if you looked at published series where there's massive screening for cervical cancer and a few end up with vulvar cancer, you have to go back and realize that there are women who incubate HPV transmission at sexual intercourse on the vulva and actually spare the cervix. And so the progression of disease will actually have a differential. This is why for squamous cell carcinoma oropharynx, we now have evidence from literature that oral sectors contribute because the mode of transmission itself must be looked at. That's why even for now among MSM cohorts, that's why it's quite a strong signal. It's actually more efficient for anal transmission on a single exposure compared to transmission on the cervix. So yeah, one has to look at that. And the other thing to learn, which really weakens us as a site, is we really don't have logical, like, not so much logical, but we don't have like other sites, a reference system where, like, I think that's what Bismarck is trying to say. I mean, I've spoken to colleagues at the Newlands Clinic who are doing a remarkable job, but the frustration is even their referrals, lots of them don't even come to Pari or any of the sites because they end up struggling to go to Karanda. And Paul Thistle does quite a good job there, whatever he can. But it's because the the referral systems are essentially malfunctional because they need to pay this fee, there, that. So for you to have a reliable database, yeah, it's so difficult in a malfunction system. But I think hopefully, Bismarck, hopefully the system will get better so that the disease should be centralized and one team looking after it for efficiency would be the best approach. Thank you.
Thank you very much, Prof. Yes, I quite agree. Yeah, the system is not centralized at all. And I think some patients who are being referred from some of these places end up getting lost and don't come to the central place.
Thank you so much. Dr. Nyakura, your hand is up.
Thank you, Dr. Matege. Thank you, Dr. Magwali, for the nice presentation on the trends of vulvar carcinoma. When you look at the trends, they sort of remained stagnant until about 2013. That's when we realized there was a peak there. Is there any explanation to why we got that peak in 2013? And what we have done to result in the rate staying at almost the same level? And then the second question, there's one of the youngest clients that you noted was a 19-year-old lady. Was there any particular risk factor that she had to have a vulvar carcinoma at such a young age?
Thank you, Mike. Okay, sorry, yeah, one thing I forgot to mention, let me just go back to that slide. We had sort of like a dip in the number of reported cases in 2008 and 2009. And those ones we actually thought were due to the disruptions that we're having in the healthcare system at that time. If you remember 2008, there was also almost like total closure for some of the institutions for quite a long time. So we thought that patients were having big problems accessing care, and also that the work of the Zimbabwe National Cancer Registry was being hampered because they go around the institutions on a regular basis, collecting the data. And so the patients were not coming in, some of the institutions were closed. So we thought that was responsible for the low numbers there in 2008 and 2009. Because in 2010, the number of reported cases immediately picked up. And yeah, as far as the peak is concerned, I think it will also be good when we come to the stage of calculating the age standardized rates, just to see whether that trend is going to be maintained when we do. One of the criticisms for this data, which some of the editors made, was that we did not calculate the age standardized incidence rates. But we hope to do that if we get the correct figures from ZimStats as far as the population structure is concerned, the number of women in each age group for each year. Then we'll see whether those trends are maintained, and maybe to give us a better view or understanding of what trends are actually doing.
Okay.
Then the 19-year-old, unfortunately, she had congenital HIV infection. She had never had intercourse, but somehow she had vulval warts. And when she presented, her disease was very advanced. She was stage 4, and we discharged her for palliative care. She was coming from somewhere in the Midlands.
Okay, that's okay. Thank you, Dr. Magwali.
Thank you, Mike. And also, Dr. Nyakura, you were the author of the case report for the adenocarcinoma. Yes. You're one of the authors.
Yes, I was one of the authors. We published the case of a 55-year-old patient who had adenocarcinoma of the vulva, which was actually a metastatic disease from large bowel.
Okay, and she had been treated in Botswana.
Yes.
At one stage by our colleague there, and then
yes,
this editor, yeah, and it was recurring all the time.
Yes, she had quite a lot of encounters with the obstetrician, and the gynecologist was seen by one of our colleagues in Botswana. She came here and we saw her several times, and we ended up going in together with the general surgeons.
Okay.
Yeah.
All right. Thank you very much.
Thank you.
Well, I don't see anyone else raising their hands. I see the admin is posted on the chat that those who require CME certificates, please email to our email, but ZSOG members essentially don't need to. Maybe as a parting shot, Dr. Magwali, if you're actually looking at treatment and if you try to marry that to one of your slides was talking about a decreased, peak age of incidence, or the mean age of incidence being now in much younger women who might actually be quite very sexually active, and surgery for vulval cancer may involve a lot of disruption of their genitalia, and sometimes including a total vulvectomy. Have you also come across or looked at, follow-up of these women in terms of their psychosocial well-being, in terms of sexual function, going back to be the women who they were after these surgeries?
Actually, very interesting, Bismarck. We had actually developed a relationship with the plastic surgeons at Paris when things were functioning well. And especially for the young ladies, I think, if my memory serves me well, about 3 or 4 of them, we actually involved after the primary dissection. We got the plastic surgeons to come in and to do reconstructive surgery, and the results were satisfactory. I remember one of them, in fact, 2 of them, later got a bit depressed whilst they were still in hospital, mainly from the prolonged hospital stay and before the reconstructive surgery. They actually got quite depressed. But after the reconstructive surgery had been done, they went home fairly satisfied with the final results. But it's something which is topical as well in the treatment of vulval cancer. The destruction to the vulval anatomy is considered to be better now that we've abandoned the radical vulvectomy with inclusion of the inguinal femoral lymphadenectomy in one incision. It's wherever possible, we now do the wide local excision and separate incision for the inguinal femoral lymphadenectomy, depending on what we feel the stage is. So yes, we can discuss that in a future session. And also, I think I can be, I'm in a position to get the records of this other weird reconstructive surgery, and we will try to follow them up with the contact details just to find out how they are getting on, because they are fairly young women.
Okay, thank you very much. The reason I asked was because I was fortunate to assist Bothwell in 2 of his cases that had come to him, and they all refused something very radical that I was actually including the clitoral area and the like. They actually signed and said, no, please don't touch that area. You could see that there's actually disease besides extensive counseling. So it just got me, questioning that, look, what else can you do? Because it will be, to me, somewhat substandard treatment if you are going to leave disease, because the patient feels that if you are going to remove that area, they might probably not function well as a woman.
Yes, actually, it's something which is topical in surgery for vulval cancer. And sometimes you get the feeling that it's not only the young women who are concerned with this, because we've had 2 women over 45 years who had actually big issues with this kind of surgery, where would remove the clitoris and the larger part of the mons pubis. They had issues with that.
Okay, thank you so much. I don't know, do we still have any burning questions?
Also, mine is not a burning question, but mine is just an overall research agenda. This disease is sexually transmitted through the human papillomavirus. And what we have to look at in terms of those countries who are fortunate to have national data, what they're looking at is the wide availability of antiretroviral treatment from 2006 and WHO 2015 announcement that people who are newly infected with HIV should be studied with antiretroviral treatment. So the speculation in terms of research agenda is that you should have a demonstrable impact of this disease within the next decade. But unfortunately, again, because of poor data collection, we do have a very good program for even vaccination. The other thing I was going to add is that if you look at Newlands Clinic, they now have a program to vaccinate all perinatally acquired HIV adolescents. And as you know, the ZIM program is vaccinating with 16, 18, the 9 to 13, and all that is meant to have an impact. But with poor research infrastructure, what would have been good, Bismarck, is to have cohorts. You can create a cohort of young adolescents, 9 to 13, follow them up when they have a sexual debut. You can do an HPV test and follow them up when they convert, if they are, one is unlucky to convert to HIV seroconversion, see if the HPV was acquired by a different serotype from the vaccine. So, but all this is occurring, unfortunately, in countries of high resource because they are forming cohorts and we have absolutely nothing. So it's a very painful thing to see because somebody from outside is going to tell us that, yeah, these are the results. And this is the likelihood for Zimbabwe in the next decade. So yeah, that's just like a global picture I was trying to paint. Thank you so much.
Okay, so yeah, thank you so much for an interesting presentation, Dr. Magwali. I see we do not have any other contributions or questions, and I'd like to thank everyone for participating. We are continuing with our weekly CMEs for this month of September. I think this is probably the last one, is it not, Veronica? Because next Thursday will probably be October. So this is the last one, and Veronica is busy sorting out issues of CME points, and for those members here, I still encourage you to get in touch with our secretary, pay up your subs, as this will avoid disruptions when it comes to working out on your CMEs and their presentations to council for registration for next year. For any inquiries, get in touch directly with Veronica or on the email provided. I thank you so very much for attending, and thank you so very much, Dr. Magwali, for the interesting talk. Thank you, everyone.
Thank you very much, Bismarck. Thank you for hosting us.